Then the last area that I was going to touch on is vaccinations and what we think we should be doing for patients in terms of vaccination. So you may or may not know that you can vaccinate individuals with proteins or killed bacteria or viruses, or you can use attenuated microbes or viruses. The attenuated agents are agents that have been grown and they are alive, but they don't cause the actual infection. And so you can vaccinate individuals. Individuals actually get an infection, but it's not the clinically significant infection associated with a disease. So for example, the polio virus is a live vaccine. The individuals get the vaccine, they get infected with this virus. The virus doesn't cause the disease, but when individuals develop an immune response against that attenuated virus, they also have protection against the virus that causes the disease. But because of the defects in patients with CLL and their immune system, we don't recommend giving any live attenuated viruses. So individuals should stay away from those live viruses, particularly polio. I get frequent questions about yellow fever, so individuals shouldn't get yellow fever. And also importantly is the zoster vaccine. So this is the chickenpox vaccine that's given, and we don't recommend that patients get that vaccine. The vaccines on the top are the killed vaccines or the protein vaccines, and I just want to touch on a couple things with regards to those vaccines. We know that patients with CLL have low levels of antibody in general, and when they receive vaccines, they have a blunted response. So if you take 100 normal individuals and you give them tetanus toxoid, for example, most of them will generate an antibody response. But for patients with CLL, because they have an immune system that's not functioning normally, probably about 50% of them will generate a protective antibody response. So there are a lot of things that we need to learn about in order to enhance the immune response, and those are areas that we're working on. Strategies like adding GM-CSF, which is an immune-enhancing molecule, to vaccines, etc. One strategy that has been published and I think that deserves further follow-up, and nobody's really followed up on it, and it was originally published back in '95, was giving ranitidine in patients who are receiving vaccines. And in this case, they gave 3 different vaccines: Haemophilus, tetanus, and influenza. And in the patients who got the Haemophilus vaccine with ranitidine, they had a significantly higher number of those patients had protective antibodies with the vaccine than the patients who didn't get the ranitidine. Now, ranitidine is an agent that you can get over the counter. It's used for acid indigestion. And this was an interesting observation, I think, and people talk about it. You see a lot of it on information about this on the web, on the ACOR website, but nobody's really followed up with this, and I think this is an interesting area that deserves further follow-up. A couple other interesting observations that I think are important for people to know relate to the next 2 slides, and they're my last 2 slides. One is that in these studies, if you look at vaccination against pneumonia, or if you look at vaccination against Haemophilus, patients who have earlier stage disease are more likely to get a response against the vaccine. So earlier is better for patients. Earlier sooner after their initial diagnosis, if you receive a vaccine, you're more likely to get a response. And also responses are more likely in patients who have higher antibody levels and in those patients who haven't had prior chemotherapy. So I routinely recommend patients get an annual flu shot. The flu shot changes each year, so individuals should get my patients, I recommend an annual flu shot. I think pneumococcal vaccination is important, and in these studies, more benefit can be seen if you give it earlier, and I usually will recommend giving it every 5 years. And I think it's important for patients to know that they should stay away from the live attenuated viruses. We're working on developing vaccines, so you can see even with agents that patients should generate an immune response against, like tetanus toxoid or Pneumovax, there's a blunted response. It's even harder to generate an immune response against their own body tissues. And one of the body tissues that we really would like to generate an immune response against is the leukemia cells. So we're working on developing strategies to train and generate an immune response against the leukemic cells, and we're studying in the laboratory ways that the leukemia cells confuse and disrupt the immune system. But you can see that even in the best case scenario, the immune response is blunted, and we really need to continue our work and work aggressively towards improving these strategies and improving or developing strategies to train the immune system to recognize and respond against the leukemic cells. And as Michael said, I think that's really where the future and cure of the disease lies. So there's a lot of data. Hopefully I covered things generally enough for you. And thank you.